Hello and welcome to our live webcast, Local Anesthetics. Where are we going? Where have we been? Thanks for joining us. My name is Kurt and I will be the moderator for the presentation today. Before we get started, I'd like to take a moment to acquaint you with a few features of the web event technology. At any time, you may adjust your audio using any computer or device volume settings that you have available. On the right-hand side of your screen, you will see the Q&A window. There is a large window which holds your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question or a comment, click in the text box at the bottom and type in your text. When you're finished, simply click the send button or press enter. All questions that you submit are only seen by today's presentation team. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. To receive your CE credit, you will need to complete the assessment quiz in order to print your letter of verification directly from the webinar site. You will be prompted to complete the quiz following the conclusion of the webinar. For those of you participating in a group, if you would like to obtain CE credit, the person who registered for the webinar will receive an email following this event with instructions. They can forward that email to the group. If you have any questions regarding group registrations, please contact us at webinars@osseo.org. That's OSSEO.org. If you require technical support at any time during the presentation, please contact us at 888-705-6002. International attendees can call 858-201-4136. It's now my pleasure to introduce today's presenter, Dr. Brent Hutson. Dr. Brent Hutson, graduate from the Baylor College of Dentistry in 1993. After serving in the United States Navy, he returned and earned a Master's of Science in Health Education. He is an associate clinical professor and has served as the director of clinical fixed orthodontics at the Texas A&M College of Dentistry for 11 years. Dr. Hutson also attending clinical staff at Baylor University Medical Center and Charles A. Sammons Cancer Center. He is one of the attending clinicians in the Output Oncology and Transplant Dental Clinic at Sammons Cancer Center. Dr. Hutson is also a captain in the United States Naval Reserve and throughout his career has supported multiple missions throughout the world. Dr. Hutson, welcome to the presentation.
Thank you, Kurt, and thank you to the Academy of Osteointegration for having me. It's a pleasure to come and speak with you about local anesthesia, which is a very, very important part of our practice as dentists. We don't have a lot of drugs that we use, but we use local anesthesia nearly every day. It's safe and effective, but sometimes a lot of us don't know, and I am guilty of that myself, knowing as much as we probably should about local anesthesia. So it's helpful to review, and I review local anesthesia myself, especially in my private practice and managing medically complex patients. So having said that, in a brief introduction, we'll go right in. And of course, when we begin any procedure, we do our patient assessment. We have a procedure we want to execute for production reasons to deliver a service to the patient, and we want to do that in a safe and effective manner. And again, patient assessment and planning are very important, and knowing things like maximum anesthesia dose and local anesthetic dose and drug interactions are very important. We want to avoid something like EMS having to come to the office. And so that patient assessment and being cognizant of drug interactions is very important, because when you do have a situation like this where the EMS has to come, it's very upsetting on a lot of different reasons, not only for your production, but just to the overall environment. And this was an incident that happened in our undergraduate clinic. And when we did the hot wash on it afterwards, it was traced back to, not having a good patient assessment and having attention to detail before the procedure began. So, hate to start on a somewhat sour note there, but it is important to know that we have to be professionals about this. So things are changing. I remember back when I was in dental school back in the late 80s and early 90s that I didn't have many patients taking very much medicine, but now, as you're all acutely aware, most of our patients take a long list of medications, and there's a lot of reasons for that. Research and development, diagnostic thresholds. I'm sure you all saw the recommendations that came out just last month from the American Heart Association and the American College of Cardiology, lowering the diagnosis thresholds for hypertension. And we're discussing that at our institution right now, how that's going to affect our hypertension guidelines for who can be managed safely, anesthetic dosages, and it has a lot of implications. There's also a paradigm shift with the population. Folks are living longer with advances in medicine and pharmaceutical industry. People with historically terminal illnesses are now living and functioning in society, and they find their way into our dental offices for treatment. And it's a complicated situation, and again, it goes back to patient assessment, and we have to be better stewards of that. So we have universal precautions. I won't spend a lot of time on this, but at least here in Texas, we have some rules with our state board about everything listed here, and not only is it our rule and law here in Texas, but these are just good common sense things that we can do to ensure that we have a uneventful treatment with our patient. So detailed health history is very important. Sometimes you have to ask probing questions. Patients don't always disclose all their information, or they may not know, for instance, that they were exposed to a bisphosphonate drug as part of their treatment for metastatic breast cancer 10 or 15 years ago. It's important to know that information. Detailed dental history if they've had trouble getting numb from local anesthesia, if they've had unorthodox reactions to any of the agents we use in dentistry, all very important to know, and an accurate list of medications. In addition, we should always do an oral cancer screening exam, head and neck exam, vitals, and I think temperature is very important and somewhat underutilized. Very important part of the vital sign process. Only takes a few seconds to get a reading like that. So when we discuss a med list, very often we'll get something like this on the upper right, where you may have drugs that are even spelled wrong. You don't get a dosage. It just says 2 times a day. And you don't know who prescribed that medicine. Getting a detailed med list with the medicines spelled correctly, the exact dosage is very important. It gives you some hints about how severe the patient's disease might be, and the physician who prescribed that medication in case you would want to get in touch with them for modification of the medication regimen, or maybe to find out why the patient's taking it if they didn't disclose a condition that would indicate that medication in their health history. Just helpful information. So we've had to work hard on that. We start off with a worksheet, which is what you see at the upper right, and then working with our staff, and then finally approved by the provider, we get to a more detailed list. Reference materials are very important to have. So many drugs coming to market so quickly, you cannot commit it to memory. Even the physicians I work with have to use reference materials to stay on top of things. There's a lot out there. I guess it's okay to mention a trade name, but I have Hippocrates on my phone, and I use it a lot. I find it very helpful. It's free. There are others. They all work in a similar manner. The thing I like about Hippocrates mainly is that it's free. It has black box warnings on there. It tells you the pharmacology of the drug. It gives contraindications, cautions, adverse reactions. It also, with the free version, has a multi-check where you can actually type in different drugs, and it will run a check and tell you if there's any interactions between those drugs. ASA classification is really considered a standard of care, especially if you're doing any sort of sedation at all. But really, for all our patients that we're going to be giving local anesthetic to, we should have them categorized. American Society of Anesthesiologists, 1 through 6. Most of our patients, hopefully, are going to be here in the 1 through 3 range. Occasionally, in the hospital setting, we will get into patients that are in ASA 3 and ASA 4 category, but looks like I've lost my slide advancement pane for some reason here. Kurt?
And we'll get that right back to you. Here we go.
Okay.
changed. There, should be right back now.
Yeah, something reloaded on my screen. Frightening. Thank you.
You're welcome.
So most of our patients are probably going to be in ASA1 through ASA3 category that we treat in the outpatient setting. Occasionally, like in our cancer clinic, oncology clinic, we will see patients down here in the ASA4 clinic, and we also take care of our transplant patients, and we'll be called in on some of those patients that need mainly extractions prior to transplant. They will actually be down here the class 5 range. End organ failure, actually needing a organ transplant within the next 24 hours. But most of our patients we treat in the outpatient setting are up here, and of course as you advance down, especially with end organ failure, significant cardiovascular disease, it's going to affect anesthesia dosages. Medical consultation is always helpful. You can often get additional information that the patient hasn't readily disclosed in their health history, or maybe they're not quite sure, if they need to be pre-medicated. They know they have some sort of cardiovascular issue that may have been repaired and you want more information. But sometimes even on our form, this is from our institution here, it has a box here that says patient is unconditionally cleared for dental treatment. And what we've learned over the years is that even if the physician checks this box and says the patient's unconditionally cleared, we're still responsible for knowing things about the drugs we're going to use, limitations on local anesthetic dosages, and interactions, and how to manage complications. So this, sometimes we look at this form and we kind of feel that it's a get-out-of-jail-free card, and we don't have to be cognizant about things like bleeding tendencies and local anesthetic dosages. It really means that the physician is not currently trying to manage a condition that they would like to have more time to manage before we begin our dental treatment. And also to gain information about things that weren't gleaned in the health history. But it really can't be viewed as a complete get out of jail free card. So let's look at some contraindications to local anesthetic, and this would be the local anesthetic, the amide local anesthetic component of the cartridge. We don't use many esters anymore in dentistry. The exceptions to that would be things like tetracaine that are used mainly as a topical type preparation, and septicaine or articaine does have some ester properties to it, but for the most part we use amide local anesthetics. So end organ failure, either congestive heart failure, obviously would be concerned about that, something like dilated cardiomyopathy where the patient's heart's not functioning well. You have to be cognizant about local anesthetic because it can, of course, decrease myocardium function. Hepatic disease where local anesthetics are metabolized. Obviously, end organ disease, they don't metabolize it quickly. They're at increased risk for local anesthetic toxicity. And renal disease where local anesthesia is how it's excreted. And if they have end-stage renal disease, then they can accumulate local anesthetic. They're also at increased risk for toxicity. Documented allergies, and this wouldn't be, my heart races or things like that, psychogenic type reactions. This would be documented allergies to local anesthetics or components of local anesthetics like bisulfide, that's a preservative and local anesthetic that contains vasoconstrictor, or preservatives that you see in multi-dose vials. And we don't use a lot of multi-dose vials in dentistry, so that's not really applicable to us. Opioids, I put a question mark there. When you're sedating patients with opioid medications, it does affect your total dose, and if you do IV sedation, you probably already know about that. We also now have to think about it with patients that may be taking opioids as part of chronic pain management. If they're taking high-dose opioids, again, it reduces your maximum doses. Usually, we look at the opioid doses that they're taking, the type of opioid they're taking, and we'll either half or half again our maximum recommended dosages of local anesthetic, and we'll talk about that. So vasoconstrictors, they have their own set of contraindications, and sometimes you'll see these listed as absolute contraindications. And, as you get into dentistry, you realize sometimes there aren't any absolutes, and that's the case here. Sometimes in our medically complex patients, especially in emergent type situations, we evaluate the patient, we cautiously proceed, and we know that there are contraindications, but we weigh the risk and benefit to the procedure, and we proceed. So, of course, uncontrolled hypertension, refractory arrhythmias like paroxysmal ventricular tachycardia, paroxysmal atrial tachycardia, atrial fibrillation, all considered refractory arrhythmias if they're refractory to treatment. So we proceed cautiously and again adjust significantly anesthesia dosages, and we'll talk about that in a few slides here. Recent MI or CVA event, unstable angina, if they've had a coronary artery bypass graft recently, uncontrolled congestive heart failure, or true hyperthyroidism, which is exceedingly rare. That's not hypothyroidism. They're very different, and that's a whole other lecture that we won't get into. But hyperthyroidism is worrisome, and you would know a patient if you saw them with hyperthyroidism. Usually they're quite ill, and it looks like I just had another refresh of my screen, Kurt. So when that comes up, if you could get me well, there it is. So I apologize about that. I'm not sure why my web page is reloading, but it looks like we're up and running again here. So a word about epinephrine dosages. The manufacturer's single maximum dose is 200 micrograms per dose. 11 cartridges when you do the math there. And if you do some reverse algebra, you see that's about a 150-pound person. And that's going to be a repeating theme with these local anesthetics, is all these calculations are based on about a 150-pound person. And that is interesting, and it's important because I find myself treating a fair number of people who come in under that 150-pound benchmark. So this epinephrine dosage is halved in the presence of cardiovascular disease. So that is someone who's maybe been diagnosed and taking a couple of blood pressure medicines or blood pressure medicine and a cholesterol lowering medication. We know they have cardiovascular disease, so we begin to be more conservative in our dosage of those patients. And then it's halved again in the presence of significant cardiovascular disease. And then the big question is always, what's your definition of significant cardiovascular disease? Well, that would be cardiovascular disease that limits daily function. Are they able to walk from the parking lot into your office? What's their exercise tolerance? Exercise tolerance is really how we measure and evaluate whether they have significant cardiovascular disease. If they have very low exercise tolerance, have to take breaks and rest after walking 50 or 100 steps, then that's considered, in our opinion, significant cardiovascular disease. There are some drug interactions that we know about. Tricyclic antidepressants are right up there, probably at the top as far as being one of the oldest known drug interactions that we have. This would be from the nonspecific tricyclic antidepressant group. Elavil or amitriptyline is probably the most familiar drug that you may have in that group. And it blocks reuptake of amine neurotransmitters and depresses the myocardium. Adrenergic vasoconstrictor is potentiated by tricyclics, and you get a really weird interaction where blood pressure goes up, and they're prone to dysrhythmias. So it's present interaction with epinephrine, L-norepinephrine, and norepinephrine also have that interaction. And actually, L-norepinephrine and norepinephrine are more pronounced. We generally stick with the epinephrine-containing local anesthetics. So in those cases we don't use L-norepinephrine, and we go with epinephrine limited to 2 cartridges. So it's halved and then halved again, just like a patient that would have significant cardiovascular disease. Non-selective beta blockers, you don't see these too much. Usually patients that have end-stage congestive heart failure take drugs like Coreg, propranolol, So in those patients where you have a non-selective beta blocker, both beta 1 and beta 2 receptors are blocked. Epi becomes a pure alpha agonist, and it's dose dependent, but you get elevated blood pressure and reflexive bradycardia. So again, we limit epi to 2 cartridges in those patients, and we monitor them during the procedure, blood pressure-wise. Most of us know about the interaction with cocaine, pretty well documented. There have been some documented deaths in patients receiving vasoconstrictor containing local anesthetic within close proximity to cocaine exposure. So I think most people know about that. Alpha adrenergic receptors, and occasionally you'll see these in patients that have BPH or benign prostate hyperplasia. Some antipsychotics also function as an alpha blocker, and you can get a beta 2 response there, stimulation and vasodilation, and actually a hypotensive crisis reaction. So hasn't been really documented with dental anesthetics, but still there's a theoretical interaction, and we use minimal quantities when we encounter patients like that. So we've kind of touched on some overview about drug interactions and what have you. We're going to talk a little bit about dosages, and the slide here is just to tell you that I don't really have all of this committed to memory that I can recall in an instant, and I do keep a cheat sheet handy. I have it in my operatory where the patients can't see it, and I have copies of it. It's laminated nicely, and occasionally I have to get it out and look at it, and there's absolutely no shame in using reference material. Mine's very messy, and I occasionally add things to it, but I would encourage all of you to kind of make a chart with your maximum recommended dosages and lessons that you might learn over time about local anesthetic dosage. So I'll try to move ahead and talk about instrumentation. There's a lot of different preferences on this. We do use local. I used to not, but when I don't, people ask me about it. Patients ask me about it, so I use it. I think painless injections or minimally painful injections can be given without topical, but it provides some level of reassurance to the patient. Generally, we'll use a 30-gauge short or a 27-gauge long needle. All mandibular blocks or 27-gauge long is used. There is some concern and risk when you hub needles or insert them all the way to the hub with needle breakage. So we use a 27-gauge long for mandibular blocks. It can be used for maxillary injections. I like to use the 30-gauge short for maxillary injections. I feel like it just gives me a little bit better control about anesthesia placement. We also need to change needles after a couple of injections as you touch bone, and most of our techniques advocate that you touch bone. You can get bending of the or blunting of the tip. It causes a lot of trauma on insertion and retraction. This is just a SEM of a needle. It was used twice, or bone was touched twice with it, and then a SEM was taken, and you can see it's rolled over pretty well there at the tip. Apologize about the dark text on the slide. A lot of these slides are derived from various presentations, and it looks like I missed changing that font to a lighter color. My apologies. Won't talk a lot about the chemistry of local anesthetics, but we know that it works by shutting down the ability to generate that membrane potential there. There's a lot of things that can affect it. You can get some things going on outside the nerve cells here with pH that disturbs the availability of the active forms of the local anesthesia. You can get some anatomical things going on with the nerve cell and sheath that prevent penetration of your local anesthetic to get to where it needs to shut down that sodium-potassium ATPase. Affection can cause variations in this pH environment here. So all of that can come together. Also concentration, if we don't give enough local anesthesia, it can't get in there and do its job. So we'll spend a lot of time talking about chemistry. Dosages, they are important, and so these are all manufacturers' recommended dosages. There are authors that have variations on this. Most of the authors prescribe a lower dose. Occasionally they'll prescribe a higher maximum recommended dose, but it's a pretty simple calculation. When you have a 2% solution, 20 milligrams per milliliter times 1.8 milliliters. There are some anesthesia cartridges now that have 1.7 milliliters, but if you always assume that they're at 1.8, you'll never make a calculation too high, but some of them are 1.7. And then you look at the maximum recommended dose of 500 milligrams per dose, and if you've got 36 milligrams in the cartridge, 13.8. So you have two components to our lidocaine 2% with 1 to 100,000 concentration of epinephrine. You have a local anesthetic component and the vasoconstrictor component. So they both have maximum recommended dosages, and in this case, epinephrine's the limiting dose. And again, you can kind of follow the math here. It's pretty simple algebra, but we should all know how to do these calculations. And again, if you do the reverse algebra on this, this begins to break down when you get a patient that's under 150 pounds. So that's a good benchmark for all of us to remember. If we have patients under 150 pounds, we may need to adjust that local anesthesia dosage. Marcaine, a little bit different drug. First of all, most of the formulations have a 1 to 200,000 vasoconstrictor component. So that's not going to be the limiting dose in this case. It's going to be the actual local anesthetic component itself. And again, when you do the calculation, it breaks down with about a 150-pound patient. This is a good drug, slow onset, long duration. It's good for long procedures, also good for postoperative pain control until the patient can get going with some nonsteroidal drugs or pain medication. Septicaine, another excellent drug. Glad to finally have it here. It was available for a long time in Canada before we had it here in the United States. It's really opened up a lot of techniques for me. We'll discuss a couple of those here in some subsequent slides. It is a 4% solution. You do the math on it, and there's the interesting thing about it is there's no manufacturer listing for maximum recommended dosage, so it's assumed to be the same as lidocaine. Because, as I mentioned earlier, it has some ester and amide properties to it, some authors say the maximum recommended dose can go up to 600 or 650 milligrams. Common thinking among most of my colleagues is that 500 milligrams, the same as for lidocaine, is our maximum dose. But it is a 4% solution. So when you do the math, your maximum number of carpules comes out lower. And actually in this drug, even though it is 1 to 100,000, like epinephrine, the limiting medication in the cartridge is the local anesthetic. Just touch on briefly that there have been some reports in the literature about postoperative paresthesia or neurosensory disturbances in patients that receive mandibular blocks with septicaine. It has been reported, and it has been the root of some litigation. It is defendable, and there are some authors. I saw Dr. Malamed a couple of years ago, and he advocates that this drug is safe for mandibular blocks. So we generally avoid it for mandibular blocks, but just wanted to briefly bring that up. It's a somewhat controversial topic. And for patients where we either don't need very long anesthesia duration or where maybe vasoconstrictors absolutely contraindicated, we have some non-vasoconstrictor containing local anesthetics. So there's no vasoconstrictor. The local anesthetic component will be the limiting medication in the cartridge, and you have to do your calculation. They'll all be different. But again, that's the limiting dose, and once again, it's weight dependent. If you do this one out, it's a little bit different than the others. I think this is about a 90-pound person. So it would be relevant if you treat kids or super low body weight patients, but most adults could take the MRD based on 400 milligrams. So what happens when you mix agents? Well, there is a very sophisticated calculation that you can do, but generally the rule of thumb is you go to the agent with the lowest MRD. So that's to say if you had two drugs, agent A, local anesthetic A, and the maximum recommended dose that you determined for that patient was 10 cartridges, and then you decide you want to give a second agent, maybe for whatever reason. You switch to local anesthetic B, and its maximum recommended dose calculation that you come up with is 5 cartridges. Your new limit, regardless of what anesthetic you want to continue giving, will be 5 cartridges, the lowest. So unless you're really good at sophisticated pharmaceutical calculations, that's a foolproof way to do it. So we'll go on and talk a little bit about anesthesia now. We don't really have a whole lot of problems with anesthesia of the maxilla. Usually just infiltrate over the area in which we're working. We can give regional anesthesia in the maxilla, but usually infiltration is sufficient, and there are some risks associated with regional anesthesia in the maxilla. Of course, you have to be cognizant of palatal anesthesia, anesthesia there to manipulate soft tissue. So you have greater palatine, nasopalatine, and some crossover in this region here. Again, you can just infiltrate, as you all know, either way. One thing that we do notice sometimes is that patients will have teeth that are splayed, or the apex is over and oriented toward the palate, and sometimes in order to get effective anesthesia, we have to give a fairly significant amount of anesthesia there in the palate. Sometimes we do have anesthesia failures in the maxilla, and it can be associated with some innervation from the infraorbital nerve, especially in long canines or first premolars that have very long roots, and a supplemental injection up there in the buccal vestibule. This is an intraoral injection, not an extraoral injection, is what is necessary to get complete pulpal anesthesia in that region. So we do have regional anesthesia by way of a couple of different mechanisms. A needle can be traversed into the greater palatine foramen up to anesthetize the complete second division here, trigeminal nerve. And the other way would be to do a PSA, where you go up to tuberosity here. So these are interesting injections, and we have found that we do have a significant number of complications with either one. We really don't traverse the greater palatine for the V2 block, but occasionally we do have to give a PSA for a more regional type of approach. But there is an increased risk of hematoma back here, because this slide doesn't show it, but there's a pretty complex plexus of veins and very small arteries back here, and hematoma is a very significant and not uncommon complication to give a PSA block. So we generally try to avoid that, especially using septicane for infiltration anesthesia here. We've almost eliminated the need to give the PSA block. Anesthesia of the mandible is a little bit more tricky, a little bit more anatomically challenging, and we find that we have a few more issues with anesthesia failures on mandibular blocks. So this is our target area back here. I have some slides to show it. Of course, you have the long buccal, the lingual, and the mylohyoid nerve that all branch off, and those are important to us when we try to achieve anesthesia of the mandible. We also have the mental nerve, which can be helpful for smaller regional anesthesia down in this area. So we see increased failure rates in the mandibular dentition, usually associated with our target area too high, giving the anesthesia too shallow, not making bone contact and making sure we're on the medial surface of the mandible, or not giving a sufficient volume of anesthesia. So this is our target zone, and most often when we have a failure and we have access to a panoramic radiograph, we'll look, and this little anatomical entity here, the lingula, will actually be much higher back here on the ramus. And if we can come back and give a higher block with sufficient volume of anesthesia, we'll nearly always get anesthesia at that point. That's probably the highest, the etiology of the highest incidence of mandibular failure is giving it too far inferior or too far anterior. Insufficient anesthetic volume. Sometimes we have a short procedure, maybe we're uncovering an implant or doing something that's only going to take a small period, and the patient doesn't want to be numb all morning or all afternoon. And sometimes the thinking is, well, I'll just give a half a carpule of anesthesia. Very often what you wind up with is half of a mandibular block, and you can't really get your work done in a painless manner. So better technique is to use a full carpule of anesthesia, and if your patient doesn't require anesthesia for the full for a longer period, then we'll maybe switch agents to something that doesn't have a vasoconstrictor and won't last as long. Mental block can be very helpful if you're working up, in the first premolar canine area, and you don't want to give a mandibular block, or maybe you're working on all of the anteriors and you don't want to give bilateral mandibular blocks. You can give mental infiltration here. Has limited usefulness. It is somewhat technique sensitive. Generally, I'll use a quarter to a half carpule of septicane for this injection. Try to give that medication just over the mental foramen. I don't try to traverse the foramen on any of these injections, and it works quite well. With the advent of septicane, mandibular infiltration has become much more useful. I have found that I can extract teeth up here in the anterior mandible by giving buccal and lingual infiltrations with septicane. That's helpful in avoiding bilateral mandibular blocks, and you can also do this with a minimal volume of local anesthesia if your volume of anesthesia is constricted due to medical complexities. So there are a few things we always need to do for any injection. The first one is probably to always aspirate to avoid intravascular injection. Intravascular injection has a couple of pitfalls to it. First of all, you're giving your patient the drug intravascularly so they can have some tachycardia and psychogenic reaction to it. Second of all, it takes the anesthesia away from the area where you're trying to deposit it, and you won't get good regional anesthesia. You also want to use a full cartridge of anesthesia unless you're doing one of those techniques I mentioned earlier where you're not using a full carpule for infiltration in the mental area or anterior mandible. And we generally do not traverse foramen. I described a little bit about that V2 block going up the greater palatine canal, and there's a lot of complications that can happen with that injection. So we generally try to avoid that. But again, we will give injections in the PSA area, but that does not involve traversing the foramen. And when we're given mandibular blocks, one technique we will use is we'll go ahead and give a full carpule of anesthesia for the mandibular block and wait for the definitive sign, which of course is tongue and lip tingling or tongue and lip numbness, before we give the long buccal. Because with a long buccal injection, you will get some lip tingling, and the patient sometimes is confused by that. So we'll generally wait and make sure we have tongue and lip tingling before administering the long buccal injection. Now, sometimes even though we get the definitive sign and then we give the long buccal and begin to work on the patient, they'll feel some pain, pulpal. They won't have pulpal anesthesia. There have been some good papers, good research that's been done on this, and our endodontic colleagues have found that if you are unsure, you can use endo-ice, and if they do not have a response to endo-ice, that's about a 92% accurate indicator that you do have pulpal anesthesia. So we'll also look at time. Sometimes we're in a hurry, we give our anesthesia, patient says, oh yeah, my lip's numb, my tongue's numb, and we're in such a hurry, we launch in and we start to work and they begin to feel it. we think, well, we must have missed our block. But really, after you give a mandibular block, you should let it sit at least 5 minutes, 5 to 8 minutes for it to completely set up. Otherwise, you may have your block, it just hasn't had time, and you give another injection unnecessarily. So I would say at least 5-minute wait period before you think, have I had a failure? So let's look at anesthesia failures. Maxillary failures usually related to not enough solution, needle orientation, where you have the bevel of the needle pointed up and you wind up blowing a big bubble between the periosteum and the mucosa. Really, again, we want to touch bone and have that bevel oriented toward the periosteum, and if you make bone contact, periosteum's pierced, you allow an avenue for that medication to diffuse in. And anatomy, we talked a little bit about infraorbital nerve or roots that are inclined to the palatal side, where you may have to give additional palatal anesthesia to get local anesthesia. So mandibular failures, again, needle orientation, although we're not piercing periosteum back here, we usually make bone contact up here and then advance our local anesthesia needle. It's important to make bone contact to know that you're on the medial surface of the mandible. Also, am I high enough? Look at the pano, see the lingula, that I give a lower injection on a patient with a high lingula and volume of local anesthesia. So there's some other reasons why we can have mandibular failure. Sometimes it's anxiety, and even though we have the patient numb, they're anxious and they think they feel pain, or they have some proprioception and feel tugging or pressure. And proprioception is one of the last things to go, if we can get it to go, with local anesthesia. So if you're dealing in an area with infection, there can be pH issues that are associated with the chemistry of local anesthesia and the active forms of the solution that we inject, that we rely on for complete anesthesia. So that can have an effect. And dilution in the area due to inflammation and increased metabolism. So there's a bunch of reasons. We can also have some anatomical variations, and quite often the suspect is a mylohyoid nerve. If you look at some of the research that was done back in the 80s, these were cadaver studies, this mylohyoid nerve can branch off quite high, and it could actually branch off higher than where we give our anesthesia for the mandibular block. So in that case, where we suspect, and we've got good signs, lip anesthesia, tongue anesthesia, soft tissue anesthesia, sometimes what we'll do is we'll come back and give a little infiltration there for the mylohyoid nerve. This will be on the lingual surface of the mandible, right at the apex, needle touching bone. We want to avoid injecting into the floor of the mouth, salivary glands. That can lead to a lot of complications there. So let's look at how Dr. Malamed troubleshoots local anesthesia failures, and I think he's an excellent author. I've heard him speak. I have his textbook. It's my definitive source for local anesthesia. So he gives his first injection, standard regional mandibular block or variation thereof. Second injection, same technique. Third injection, you might need to think about a different technique, higher block, Gaugates, acinosy, something like that. Then more exotic things like intraligament injections, intraosseous, intrapulpal if you're doing endodontics, and then last but not least, Helix prayer, which is kind of funny. So let's look at some fads, trends, and gimmicks. There have been a lot over the years, and I don't mean that any of these are gimmicks or fads. I just kind of threw them all in here together. We do use topicals. There's some other topicals that can be used. Most of these are, as I said earlier, esters. Lidocaine patch got popular. We have the buffered anesthesia solutions, which do seem to work as far as decreasing injection pain. It does require some time, and there is some armamentarium involved, but I've seen some studies that show pretty promising results there. Orverse came out. All that is a alpha agonist that knocks the vasoconstrictor off the receptor and causes your anesthesia to wash out faster. It requires another injection. Something that came out recently that we experimented with a little bit here at the schools is Covanase, which is just tetracaine and Afrin. You actually spray it in the patient's nose. Requires a couple of doses. You can get pretty good anesthesia with it. I was kind of surprised how much anesthesia you got with it. There are some concerns about tetracaine and systolic hypertension, and this does require some redosing and requires 2 doses initially just to get where you're going. But a lot of things come out over the years that are interesting. So we'll look at some other techniques now, and a lot of folks will resort to the Gow Gates if they have a mandibular failure. And really, a Gow Gates is really just a high mandibular block. And what you're doing is coming in here from the contralateral side, and your target there is the condylar neck or lower part of the condylar head there. And what you're doing is blocking the mandibular nerve very high up here before the mylohyoid, lingual, or buccal nerve branches off, and that would certainly take into account and accommodate for things like a high lingula or a mylohyoid that branches off earlier. So those would all be anesthetized. Somewhat technique sensitive. There are different techniques, and probably best learned by having an experienced clinician demonstrate it. But it's a variation of the mandibular block. So the acinosy, I find this injection very helpful, especially on trismatic patients. It's a closed mouth block, rather long insertion there, and this is the target zone. It's done with the patient's mouth closed on the lingual side of the mandible, and you need to go back about 25 millimeters and deliver carpule of local anesthesia. Again, it's helpful when patients have minimal opening or if they're trismatic, and it is considered a high block technique. And you can see here this red dot, pretty high. You know, you're up above the CEJ of those maxillary teeth. So it is a high block technique, just a little bit of another variation. Periodontal ligament injection can be very helpful. The disadvantages to it, if you have long roots, it may not be effective, can be painful. There can be some post-operative pain associated with it. Sometimes with some of the armamentarium, you'll have these carpules explode, and it's unsettling to the patient. Have some different armamentarium. I generally prefer these pin type contraptions. I think they work well, and they aren't as alarming to the patient as this one that looks a lot like a gun. And sometimes that's alarming to patients. Intraosseous is another good technique. It works. It's safe. It's effective. There are some pitfalls to it. You do have to use a drill to penetrate the cortical plate and get into the medullary space. And you place a hub, and then you inject your local anesthesia in there. It does work. It is effective. It is safe. It is considered to be an intravascular injection, believe it or not. It has short duration, and sometimes patients do experience same type of psychogenic or cardiovascular side effects of a racing heart when that injection's given. There's a lot of different there's several different brands on the market, but again, you have to use a pilot drill. Usually a hub's left behind, and then your anesthesia goes in through that hub. It can be useful for short procedures like endodontics, where you're trying to get into the pulp, and then maybe you can deliver some intrapulpal anesthetics. So complications, we've covered a lot of these. Needle breakage, we try to avoid sinking needles to the hub. So we use a longer 27-gauge needle for mandibular blocks. We don't bend needles. That creates a weakness in the needle. And again, not to the hub, because that is the weakest spot. Pain, hematoma, especially with PSAs. You can have burning on the injection site, sloughing of tissue, especially with stronger solutions like 3% and 4% solutions. We avoid those for palatal infiltrations. Self-harm and trauma is very common. Patients go away, they're still numb, and they're trying to get back to work. Maybe they grab a sandwich and they'll chew on their tongue or their cheek, and then when their anesthesia wears off, they think that it's an infection or something that happened as a part of the procedure. And then trismus can happen. You can get hematomas even with mandibular blocks. We avoid injecting through infected tissue. That can be spread of infection, can be another complication. Facial nerve paralysis and persistent anesthesia are both fairly common. The persistent anesthesia most often associated with stronger concentrations like 4% solutions, but it can be seen with any concentration solution if there's direct trauma to the mandibular nerve. Facial nerve paralysis usually happens when bone's not touched and local anesthesia is deposited on the lateral surface of the mandible into the parotid capsule, and you cause a little Bell's palsy type reaction there. Psychogenic complications are the most common. Accelerated heart rate, can even have syncope. Reassurance is usually sufficient, and those symptoms usually pass within just a few moments. CNS toxicity is very serious. Most of us know these complications from it can lead to convulsions, tinnitus, vertigo, circumoral numbness, or some of the earlier signs. It is a medical emergency, and generally you need to give basic life support, and it's activation of your ACLS team or EMS if you're not in a hospital setting. Vasoconstrictor toxicity is about what you'd expect: heightened mental awareness, agitation, tachycardia, hypertension, and cardiac arrhythmias. We do see a fair number of needle separations referred to our oral surgery department, probably 4 or 5 per year. And they can range from benign and don't require any intervention at all to pretty significant surgery to prevent needle migration and retrieving the foreign body. It's always important to remember that when you have patients nice and numb, which is what we want, they lose a lot of their protective reflexes and they can swallow things like torque wrenches and healing caps and onlays and inlays and even bridges. And if someone does swallow something, we have to take some follow-up x-rays and make sure that it's not in the lungs, that it is in the belly. And we usually send them home with a treasure hunting kit. If they're unable to retrieve it, they'll have to come back for a follow-up KUB and make sure that it's passed. So this has been a little bit of a whirlwind tour. I went a couple of minutes long, but wanted to try to cover everything. I'll turn it back over to our moderator and try to answer any questions that you might have. Thank you.
Thank you, Dr. Hutson. And as a reminder to our audience, the Q&A box is located on the right-hand side of your screen. Simply type your question in the small space at the bottom of that box, press Enter, or click on the Send button. Please note that due to our time constraints, our speaker may not be able to respond to all questions submitted. And if your question is not answered, you can send those to webinars@osseo.org. And we do have a question that came in along the way. What are your thoughts on anesthetic buffering systems? Does buffered anesthetic have any local limitations?
Yes, Talar, thank you for sending that question. I saw it come up, and it was before I got to my slide. I mentioned it briefly. We've experimented with a couple of those systems here, and we found them to be simple to use and easy to use. I don't think it has any effect on local anesthesia effectiveness. I think it helps on onset of local anesthesia. I think it helps with pain of injection, and it really just tries to bring the local anesthesia down to tissue pH. The drawbacks to it, of course, would be that those systems aren't cheap. It takes a little bit of extra time, and that would really be the main drawbacks to it.
Our next question: is there a need for a guided needle injection?
We don't really use many guided needle injections for routine procedures. I have seen guided needle injections used in pain management and in the hospital setting for retrieval of foreign bodies or needle-guided biopsies and what have you. But me personally, I don't have a need and can't really think of a need for a guided needle injection. Hope that answered your question.
And next up, what kind of interactions do bisphosphonates have with local anesthetics? And a second part, what are your recommendations for local anesthetics for people on bisphosphonate therapy?
I don't really believe there are any interactions with bisphosphonates per se. And my go-to drug is always lidocaine with epinephrine, unless there's some specifics, like I mentioned, in the mandibular dentition, where I may want to add an infiltration in conjunction with a mandibular block I've done with lidocaine. I'll go to those, but most of our concerns with bisphosphonates have to do with manipulation of periosteum and invasive dental procedures.
Okay, we have about 5 minutes remaining, and we do have a few more questions, so we'll continue on. Can local infiltration with atropine replace mandibular block?
Articaine for mandibular blocks, can it replace it? I say yes, it can replace it in the anterior mandible an acceptable percentage of the time. As you move to the posterior mandible, it cannot. There is a technique described by Malamed where when you give a mandibular block with lidocaine or marcaine, one of those types of drugs, and you've given you've tried to troubleshoot it, you don't have complete pulpal anesthesia, a buccal infiltration, even in the molar region with articaine as a supplemental injection to the mandibular block, addresses a high percentage of those cases in achieving complete or profound anesthesia.
For sinus augmentation procedures, what is the best injection technique for sinus?
Well, I have to admit to you that I don't do sinus augmentation surgeries, but I did anticipate some questions about this since I am talking to the Academy of Osseointegration, and I talked to some of my colleagues, and I asked them specifically about maxillary anesthesia and sinus augmentation. And they said that they generally use lidocaine, 2% lidocaine with 1 to 100,000 epinephrine. And if they need additional anesthesia for short duration when they enter the sinus area, that they will often switch to a lidocaine solution with no epinephrine. That's the best answer I can give you.
Okay, and I don't see any additional questions, and we are down to the last couple of minutes, so perhaps if you have some closing comments, we can listen to those, and then we'll move on to end the program.
Well, again, thank you to the Academy of Osseointegration for having me. Hopefully it was helpful in reviewing these issues. Some of it was pretty basic. I think it's always good to go back and review the basics. Hopefully there was something there for everyone, and no one's come away dissatisfied. Thank you for having me, and I hope everyone has a great holiday season.
And thank you again for the presentation. On behalf of the Academy of Osseointegration, I'd like to thank you for your participation in today's event. A post-event survey will appear requesting your feedback in addition to the link for the assessment required for obtaining CE. Please take a moment to complete that survey, as it will help the Academy plan future web events. This does conclude today's program. Thank you, and do enjoy the rest of your day.